Welcome everyone to our Med Surg for Nurses series. I'm Scott Krueger, and in today's episode we're going to be talking about things that are concerned with the urinary system, and then we'll also be talking a bit about pain factors, things related to acute pain, chronic pain. So when we're talking about the urinary system, we want to think about the organs that are involved in it. We think about the kidneys, the ureters, the bladder, and the urethra. It's important to note that the kidneys regulate our blood electrolytes by filtration and reabsorption, as well as eliminating metabolic wastes by filtration as well. The kidneys filter about 1/4 of the body's blood at any one time. We want to consider the glomerular filtration rate, also known as the GFR, and that is the amount of blood that is filtered by the glomeruli inside the kidneys at any given time. One of the key factors that we look at when we're calculating kidney function is the GFR. That's kind of the top thing that we're going to look at. The average GFR is about 125 milliliters per minute. Other labs that can tell us about kidney function are the BUN, blood urea nitrogen, and nitrogen is a waste product. And if there's a buildup of nitrogen in our blood, that can tell us that the kidneys aren't functioning as well. One of the other tests that we can look at to monitor kidney function, creatinine. We want to look at that creatinine. So the main three tests for measuring kidney function, GFR is the main one. We can look at our BUN and then creatinine levels. Important to note, the kidneys regulate fluid volume in the body through filtration, reabsorption, and excretion. The kidneys are also important for helping to regulate our blood pressure by secreting the enzyme renin. And renin is the first part of the RAA system. So we have renin, angiotensin, and then aldosterone. And the whole purpose of that RAA system is to tell the body to hold on to water. So the RAA system is an important mechanism for preventing dehydration. However, if we have too much renin being secreted, the body's going to hold on to too much fluids, and that can increase the blood pressure. Kidneys also increase red blood cell production by secreting erythropoietin. And then also kidneys metabolize vitamin D into its active form. And in our last episode, we talked about it's necessary to activate vitamin D so that we can absorb calcium for our bones and our teeth, and then also to have calcium available in our bloodstream. Some important considerations looking at the kidneys. Cystitis. Cystitis is an inflammation in the bladder caused by a bacterial infection, also known as a UTI, urinary tract infection. Symptoms include flank pain, so this pain kind of in the kidney area, foul smelling urine, lower back pain. People may have dysuria with a UTI. Dysuria is painful urination. Polyuria, which is increased urinary frequency. In cystitis, in UTIs, urine may have a cloudy appearance. There may be blood in the urine, also known as hematuria. And there also may be pyuria present, that is pus in the urine. And if you have any of those can be possible indications of a UTI. And when you do have a UTI, it's important that we perform a urinalysis along with a culture and sensitivity. So UA, we're going to analyze urine, so we need a urine spec, and then we're going to perform a CNS, a culture and sensitivity. So basically, we're going to grow we're going to try to find out what kind of bacteria is infecting your bladder. And then based on what bacteria we find, we are going to find what antibiotic is going to work best to get rid of that infection. Because you definitely don't want to be giving an antibiotic that is not going to be effective against the invading organism. So we got to find the appropriate antibiotic for the kind of infection that it is. So important to note that in the elderly population, confusion can tend to be the first sign of a UTI. Sometimes when we're dealing with patients who have a Foley catheter, they basically have a tube into their urethra that helps drain out the urine. It's important to note that anytime anyone has some kind of tube or drain coming out of the body, if we have to flush or irrigate that tube, we want to follow that tube back to the body to really determine exactly what tube that is. So if you have a patient who has multiple tubes and lines coming out of them, if you're going to have to flush or irrigate one of those tubes, you want to ensure that you're flushing or irrigating the right tube. So you want to follow that tube back to the part of the body that you're going to be flushing or irrigating. Looking at bladder cancer risk factors, men tend to be more at risk for bladder cancer. People who smoke are more at risk for bladder cancer. People living in urban areas, or people who have jobs where they're exposed to chemicals like nitrates, dyes, rubber, leather processing. For example, people who are painters, hairdressers, textile workers, they tend to be at an increased risk for bladder cancer because of the chemicals that they're exposed to on a daily basis. So with bladder cancer, that bladder wall tends to be exposed to those carcinogenic chemicals in the urine. One of the main symptoms of a bladder tumor is blood in the urine, also known as hematuria. Looking at chronic glomerulonephritis, that is a long-term inflammation of the tiny filters in the kidneys. So you have what's known as glomeruli inside your kidneys. Those are very tiny filters. Chronic glomerulonephritis, so chronic inflammation of those glomeruli, are commonly associated with long-term kidney disorders and renal failure. Looking at end-stage renal disease, also known as ESRD, that occurs when chronic kidney disease reaches an advanced state. Your kidneys may lose their filtering capabilities. It may lead to dangerous levels of fluids in the body, as well as electrolyte and metabolic waste can build up in your blood and your body with end-stage renal disease. Patients may have to start hemodialysis or peritoneal dialysis when they're in this end-stage renal disease. So dialysis helps filter out the metabolic wastes that are in the body. Important to note that people who are on dialysis tend to produce very little urine. Sometimes they may not produce any urine at all. It may be in small amounts. That is normal for a dialysis patient. But dialysis patients tend to go 2 to 3 times a week to go get this dialysis to clean their blood, to filter out all those toxins. So that's important to note. Chronic renal failure, also known as CRF, that is a progressive loss of kidney function and develops over the course of many months or years. And that is caused by destruction of the nephrons inside the kidney. All right, looking at pain, we want to discuss some things associated with pain. We have acute pain, which is short-term, tends to have a recent onset, and can be associated with emotions such as anxiety. Symptoms can include increased pulse, increased respiratory rate and blood pressure. People can be diaphoretic, they're sweating. There can be increased muscle tension, nausea, vomiting, flushing. Pallor is that paleness of the skin, and they can be noted to either have frowning or grimacing when we're in acute pain. Chronic pain usually lasts more than a couple months, more than 6 months possibly, and tends to be associated with the emotion of depression when we're in chronic pain. You know, can you imagine being in pain on a daily basis for a long period of time, more than a couple of months? When we're in chronic pain, people tend to not want to move around as much. They're not going to be active as much. So definitely depression can set in when we're dealing with chronic pain. The human body produces substances known as endorphins. Those are endogenous opiates that attach to pain receptors in our body. Endorphins are important because they block pain sensation and they appear to modify and inhibit unpleasant stimuli. They also reduce anxiety and relieve pain. So endorphins are kind of our natural body's way of dealing with pain. However, people who are in chronic pain, they tend to have decreased level of endorphins. So in that case, they may require opiates or some kind of analgesic pain medication regime to help deal with that constant pain. Important to know about the gate theory. The gate theory tends to talk about the way that the central nervous system interprets pain signals through your spine. So in your spine, we have these things which we refer to as gates. And when those gates are open, pain sensations are allowed to pass through. When the gate is closed, pain sensations tend to be blocked. And there has been some recent research that shows that people, when they're meditating or they're consciously aware of certain ways that they can modulate these gates. So there's been some practices that look to try and control these gate theories. And when you can control these gates, you can almost control whether you feel pain severely or maybe minimally. So some of those practices really look at trying to control the way that we interpret pain signals so that we don't have to rely too heavily on narcotics and opiate analgesics. Nonpharmacological approaches to pain management include things such as heat, cold, guided imagery, distraction, relaxation, and meditation. When we're talking about younger populations, you know, it's important that we try to use non-pharmacological approaches such as distraction. You know, a lot of times when I see little kids getting shots, you kind of distract them with like a puppet or distract them with a book or something, and as they're distracted, you give them the shot. If you're able to do that pretty well, they may barely even feel that shot. So sometimes we use transdermal patches for pain relief. It's important when we're using these transdermal patches that before we apply a new patch, we want to remove the old patch first before putting on the new one. We always want to make sure that we clean the area that the old patch was removed from, as well as cleaning the area that we're going to apply the new patch to. You don't want to put patches over parts of the body that are very hairy, but also if you're going to clean that area before you apply the patch, make sure it's dry. So you got to clean it, dry it, so that patch will really stick. It's important to note in your documentation where you put the patch so that the next nurse who comes in the next shift or the next day and has to change the patch, they can go and quickly find where that old patch was, remove it, and then put on the new one. I can't tell you how many times in my practice that I found a patient has 2 or 3 old patches on. You know, that's no good. We got to make sure we're removing those old patches before we put on a new one. And sometimes we would actually date the patch as well that we put on the patient. It's important though that you don't actually write on the patch itself, write on a little piece of tape and then attach that piece of tape to the patch but just be sure that you're not obstructing any of the dosage or the medication name that's on that patch. Opioid medications can depress respirations, so we got to be really careful in our administration of them. Opiate medications can cause constipation and also increase the risk for falls. Other disorders that increase the risk for falls includes orthostatic hypotension. That is where the blood pressure falls when a patient changes their position. Also weakened patients, patients receiving diuretic therapy, patients with fluid and electrolyte imbalances, as well as medications that have a dizziness side effect can increase the risk for falls. Any musculoskeletal disorders that impair normal ambulation or balance, neurologic problems such as peripheral neuropathy, which affect the sensation in the feet, that can contribute to increased falls. Patients with balance or gait problems resulting from a stroke or inner ear disorder, patients with impaired vision, impaired hearing, extreme weakness, oxygen deficit, that can definitely contribute to falls. And then it's also important to note that once a patient has fallen once, it's more likely that they are at an increased risk for future falls. Lastly, rehabilitation is the process whereby a disabled person is helped to achieve optimal function. A primary goal of rehab is to minimize deficits associated with medical conditions and to maximize the abilities that are intact. Okay, so I hope you found this video helpful. Make sure you give me a thumbs up. Give me a comment down below if this helped. Make sure to subscribe to the channel. We'll see you on the next video.